All right, today we're going to talk a little bit about adverse drug reactions and basically this will become a review of the immune system. It turns out that a lot of the things that we have to worry about in nuclear medicine in terms of adverse drug reactions have some basis in the immune system and are an immune-mediated response. And so the point of this lecture is to talk a little bit about the immune system, do kind of a review, talk about what kind of effects you might see if you do have an immune-based reaction to the administration of a radiopharmaceutical. And then I'll give you some examples of some cases where they have tied the type of reaction that has occurred back to a radiopharmaceutical with an immune-mediated response. So today we're going to talk about the key components of the immune system and the role in immune response. We're going to talk about the different immune-mediated responses to the administration of drugs, including radiopharmaceuticals. And we're also going to talk a little bit about the difference between regular drugs and radiopharmaceuticals and the responses you might see. And then we'll talk about specific things related to radiopharmaceuticals. So when we first start talking about the immune system is an incredibly complex system in the body. And so in an hour, there's absolutely no way I'm going to be able to do the immune system justice in terms of getting into a lot of the details about what's going on. The important thing for us is to kind of just go through and do a quick refresher. We're going to touch on some terminology. We're going to touch on some things that are directly related to the immune response. But please make sure that you understand that this is not designed to be an all-encompassing review of the immune system. My pharmacy students take an entire semester of immunology and discuss several of these topics. So an hour really is just not enough to get into the details. So what I'm going to try to focus on are some of the key terminology that you probably have heard before, but also then to kind of tie that into the specific things that I'm going to talk about in terms of radiopharmaceuticals. And so you can see on this slide I've just thrown a bunch of words up: complement, killer T cells, monoclonal antibodies, T cells, B cells, macrophages. These are all terms that are directly related to the immune system in the body. And, we talk about them, people throw it around a lot, but I think sometimes we kind of forget what the role of all of these things are in the immune system. The human immune system is quite an amazing apparatus because it really does a lot in terms of protecting you from the weird, crazy things that you might expose yourself to as you live your daily life. So the immune system itself, as you can see, its function is to protect the host from evading pathogens and to eliminate disease. And it's really when you actually look at how we describe it, we really describe it in two ways, both the innate and the adaptive immune system. And these things, when we actually start talking about some of the cells and the things that are coming from the immune system, which we'll do in a few slides, these all start from one place, and actually it just depends on how they differentiate and how they change in the developmental process to end up having a function or certain function as part of the immune system. But when we look at protecting you, as we talk about the immune system, as I mentioned, we have two components: the innate component and the adaptive component. The innate system is basically what's there. What do we have in our body that is designed for this function? So some examples. I think some people sometimes forget your skin is actually a physical component of the innate immune system. It protects you from a lot of different things, and while it is still flexible and it still allows penetration of things, the skin itself is a major barrier for protecting your internal body from being exposed to external pathogens. If we didn't have the skin, we would be constantly fighting this battle of trying to protect ourselves from the things around us. We also have the biochemical component, and these are some of the words that we throw out that are complex and some people forget. Complement, we activate the complement cascade, we have intrinsic factor, things like that are all secretions and enzymes and things that are actually released in response to an immune-mediated assault on your immune system. The last one, cellular, the neutrophils, the macrophages, the actual cellular components that are actually going to do the job of the immune system. And again, we're going to talk about these more a little bit later as we go through this. But really, the innate immune system is essential in foreign body breakdown. You are going to take things into your body unintentionally. You breathe it in, you touch something and it gets absorbed through your skin. I mean, you eat things. All of those kind of components are ways of introducing some kind of foreign body into yourself. And it's unavoidable. You can't prevent it. And luckily for us, the immune system is designed to make sure that we can prevent it, because you would be living a very clustered, sterile life if you had to worry about this all the time. When we look at the components of the immune system, especially the biochemical and the cellular markers, really what we're looking at, and the whole premise of the immune system is something gets in and the body has to figure out how to find it and fix it. And by fix it, I basically mean either break it down or get rid of it. And in the process of doing that, there are several different mechanisms by which this might happen and several different cascades that start as part of this process. And the nice part for us is that for the most part, it works behind the scenes. We don't even notice that these kind of things happen. Now, every so often when we have a huge issue or a huge assault to the body, we may actually start seeing some of the mediators that are involved in this process to basically cause some evidence where you might have reddening or you might have a fever or you might have different things like that. But basically, for the most part, our body's immune system works pretty silently, and you don't even know that it's happening. Now, the second part of the immune system is kind of what we call the second defense, because while we have the innate system, it's not always perfect. I mean, unfortunately, while it's a fantastic thing, it is not always going to do everything that we want it to do. And so the adaptive immune system is kind of our backup system, and or what we call the second line of defense. And so usually what happens, though, is that we have something going on in the innate response which says, uh-oh, this isn't working. And so we release mediators, we release other markers that basically tell this adaptive immune system that you need to kick it into gear because we need more help. And so in this case, we're going to talk about antigens and antibodies. And most people have heard this terminology, but essentially what happens is where the innate system is kind of very general. It just blocks things, it stops things, it gets rid of things. The adaptive immune system has the ability to be a little bit more specific. And so once we have this issue that's kind of kicked in, the second line of defense, we actually are able to create things that focus specifically on that thing that is our problem, or the foreign body that's actually in there. The other thing that the adaptive immune system does, which is remarkably helpful to you, is to be able to tell the difference between what should be there and what shouldn't be there, or what we consider to be self and non-self. So I don't want the adaptive immune system kicking in to fight off something and then see some of my own tissue and say, ooh, that's what I want to work on. I want to get rid of that. Because that's basically your body is going to attack itself. Unfortunately, as we'll talk a little bit later, sometimes that happens, and it's called, an immune-based disease. But for the most part, this system works pretty seamlessly in being able to differentiate what should be there and what shouldn't be there. The other and the last thing I have listed on here is to respond to previously encountered antigens. Your adaptive immune system has a remarkable memory. And so basically, if you have been exposed to something and your body has formed an adaptive response to that, if you're exposed to that same thing again, your body is going to be able to recognize that and mount a defense a whole lot earlier than it would normally. We don't have to wait for this process to actually kick in. This is really the premise behind vaccines, and we'll talk a little bit more about it as we kind of get into this. But really, that's exactly what we do when we vaccinate you. We give you an antigen, we allow the body to make a response to that antigen, and then hold on to the memory of that response, so that way if you ever see the antigen again, it's able to very quickly mount a response and actually do something about it. The adaptive immune system, when we start talking about that, you're going to hear me talking, like I said, about antibodies, which basically is what we consider to be a humoral immunity. And then we'll also talk about your T cells. And basically the antibody side is kind of the B cell production. The T cells are more of a cellular type of response. And again, we'll discuss each of those in a little bit more detail. Again, not anywhere near as extensive as we probably could, but enough to give to you an understanding of kind of the premise of what we're talking about today. So I'm going to start with T cells. T cells start in the bone marrow, from a stem cell in the bone marrow, and they actually are released from the bone marrow. And we can actually do two different things, depends on where they go. So usually what will happen is these T cells will actually migrate to the thymus, which is an organ that is actually found in the upper chest area. Most of the time in children, this is much larger because the thymus is actually working and trying to figure out some of the stuff that we need to deal with. As you get older, it gets smaller because it's not used as often. And we can actually try to we should have already formed most of the responses that we expect to see. Now you'll notice in this picture that I showed you, we have the T cells, that's kind of the upper arc of this picture. B cells also start in the bone marrow and migrate somewhere else. So we're going to talk about that in a few minutes. But basically we have the pluripotent stem cell. It's released, it goes to the thymus, and then for the T cell perspective, in the thymus, this is where the T cells acquire the ability to differentiate between self and non-self. If you have basically self, if it's an antigen that, or a cell that actually recognizes yourself, the T cell, the body is able to look at that and say, hey, that's part of us. And so that particular T cell basically dies off. And that basically tells our body that this is not something that we need to be attacking, that we don't need to be taking care of, because it's part of us. And this is why you can kind of see this happens a lot when you're younger, because obviously we need to develop that response very quickly after birth. And so basically we have these T cells that are actually, we look at them and say, we don't need you, and we're not ever going to need you, we hope. And they tend to go away. The ones, though, for non-self, where basically we have this, what we call positive selection, when we have this, we recognize this and we say, oh, wait a minute, these T cells might actually be useful to us in the big picture. Let's make more, and we will hold on to them. So that's what we call positive selection, and usually what happens then is you make more T cells and they kind of move out to the rest of the body. A lot of times they're going to be in lymph nodes, kind of sitting there waiting. You see them in most of the organs of the immune system, like the spleen. They are circulating around to some extent in the blood, because they're going to be kind of our first line of defense against a lot of foreign invaders. But basically at this point we have a whole bunch of them, we hope. And then once we need them, we hopefully will be able to use them and use them quickly. T cells are actually divided into two different types, what we call the cytotoxic T cells and the helper cells. And so you'll hear us talking about cytotoxic T cells, or T cells, a lot of people just call those T cells, or helper T cells. So as you can see here, this kind of gives you a little schematic of what actually is going to happen when a T cell encounters something that that's not supposed to be there. That's basically a foreign molecule in the body. So these cytotoxic T cells are really our killer cells. So you can see here we've got an infected cell what we're going to consider to be our abnormal cell. And these cytotoxic T cells kind of float around, and when they recognize something that looks foreign, they will bind to that. And inside of a cytotoxic T cell is a molecule we call perforin. And perforin does exactly what you think it would do. Perforin tends to perforate. So when we actually bind to that cell, and the cell the cytotoxic T cell recognizes the infected cell as being foreign, it's going to bind onto it, and it's actually going to release this perforin out of the cytotoxic T cell, and it's going to actually go in and it's going to attack that infected cell. And perforin is going to basically pop little holes all over in this, which is going to cause that infected cell to basically lyse and go away. And then the T cell, once it's done a job, can go away, and basically you now have a no longer viable cell. And your body is going to clean that up basically as it normally would. But now we basically essentially popped the bubble. We popped that particular cell, and it's no longer a viable cell. Now, when we look at how this is actually done, we usually will see that T cells will bind to certain things that are presented when you have this infected cell, or a tumor cell is another one that's going to happen. And so basically you have these peptides and other molecules that the body actually produces and releases in the presence of these types of cells. And so once this actually happens, the T cells, when they recognize that, are what we call activated T cells. And so again, as I showed you in the schematic before, once those T cells become activated or actually engaged with that particular cell, then it's going to work until we actually kill off the target cells by ways of the perforin and other enzymes that actually will kill it off. Now, the other type of T cell, the helper T cells, is a little bit different. Basically, and this is a little bit more complex type of thing, helper T cells are kind of the intermediary between our cytotoxic T cells and our foreign antigen. Helper T cells are also going to be involved in the B cell side of immunity, which we'll talk about in a few minutes. But in the helper T cell kind of component, you can see in this schematic, we have something that is actually, in this case, an antigen. So you've got this cell that is actually displaying this antigen. And then the T cell receptor is still there, but instead of binding to a cytotoxic T cell, maybe we haven't called that cytotoxic T cell strong enough and it hasn't gotten there. Or maybe the helper T cell gets there first. But regardless, the T cell is going to bind to that molecule just like we talked about before. Now, at this point, this is basically where the helper T cell kind of sends out the call. And depending on what type of thing that we're looking at, if it's something that the body knows that we have the mechanism already to try to deal with, like using a T cell-mediated immunity, the helper T cell basically kind of calls out and says, we need you to come here and do your job. And so the cytotoxic T cell then is going to migrate towards that area and basically eventually still bind to the cell and release the perforin and actually do what it's supposed to do. So essentially, it's kind of the middleman in between this process. The B cell side, where we talk about antibodies, if the helper T cell recognizes that we don't have the right cytotoxic component to do this, it may be something that will actually be mediated more on the B cell side. And so the helper T cell can also call B cells and basically get them involved in the process if that's what's actually needed. So the helper T cell itself doesn't really necessarily kill things, but it promotes things that will help the killer cells do what they're supposed to do. So if you look here in this slide, the helper T cells, there are actually two different types of helper cells. The first one, Th1 or helper T cells 1, secretes various substances, interferon, interleukin, tumor necrosis factor, complement, things like that, that basically says, hey, I need help. And so at that point, this is how we get the cytotoxic T cells, some of the other natural killer cells in the body, macrophages, which are floating around in the body, and basically it activates them and tries to pull them in so that they can do their job. The Th2 or the helper T cells 2 is the side that tends to promote more of the B cell proliferation and differentiation. And again, we haven't really talked about B cells yet. I'm going to do that next. But basically, that's what we're going to see here in this process. So just think of the helper T cells as exactly that, helpers. They're going to help identify what part we need, T cells or B cells, and help pull them in to actually do the job that's supposed to be done. Now, I mentioned natural killer cells. We do have natural killer cells that are just floating around. I mean, while that process, the whole T cell activation, is not a lengthy process, it does take a little time, especially if you have to call other things in or other cells in to help actually work on getting rid of the foreign cell. And so a helper T cell kind of floats around, and basically they don't need to be activated. We don't have to do anything special. It's kind of like bumping into a bad guy. And so this bad cell, we come into contact with it, the cell says, hey, you don't look normal, and just kills it right there. And, you know, luckily for us, that helps mediate a lot of our problems, because before anything has a chance to proliferate or grow or to become a problem, this is how we get rid of a lot of the foreign bodies that show up in our system from whatever reason it actually happens. So these are kind of the fast guys, the vigilante type of justice that you're looking at, where we identify it as being bad and we just fix it without even discussing it. It's just done. All right, so the last type that I want to talk a little bit about are B cells. B cells are the type of immune markers that actually lead to the production of antibodies. So, as we mentioned, T cells and B cells both come from the same place, but basically the cells that are destined to become B cells are going to move to the bone marrow, out of the bone marrow into lymph nodes, and basically they're going to be available for our use at some point in time. And what ends up happening with B cells lead to the production of antibodies. And antibodies are specific molecules that are going to specifically target something, in our case an antigen, on a cell. And so these antibodies kind of circulate around and basically are a sentry. They're looking for stuff. And if they happen to see and say, oh, look, I found this antigen and it matches my binding spot where I'm designed to meet a particular antigen, then it will bind on, it will latch on, and then basically you will produce more of these antibodies to try to get rid of them. So really, if you look at the difference between a T cell and a B cell, they look about the same because they essentially came from the same place. The only thing that makes them different, they do have some different cellular markers. But like I said, these are basically surveillance. The B cells don't just produce antibodies all the time, but the B cells themselves, as I mentioned in that previous slide where I showed that the helper T cells, the B cells itself are floating around, and when they come into contact with a cell, the B cell can actually bind to an antigen. But once it does that, it can't really do anything until you get the helper T cells to kind of activate that process. But once the B cell is activated, where we recognize, oh man, this is a problem, we need to do something about this, then the B cell is going to start spitting out these antibodies so that we basically have a ton of stuff ready to go in case there are more. Because the problem that you have is that we might find one cell, but we don't know if there's just one cell or if there's 100 million cells. And so once a B cell actually identifies its specific target, it's going to start producing stuff to make sure that we've got plenty of antibodies floating around so that wherever in the body one of these similar cells are going to be found, we hopefully are going to be able to grab it and get rid of it very quickly. So B cells also are divided into two different types, and with two slightly different functions. The first are the plasma B cells, and in this case, the plasma B cells are actually the antibody producing, the antibody factories. And so once the B cell is actually binding to an antigen and the helper T cell comes in and says, whoa, yeah, this is bad, all of a sudden then these plasma B cells are going to be targeted for production. And at this point, they become a little production machine. And usually what you'll see is the plasma cells are going to migrate to one of our main organs involved in the lymphatic system, usually the spleen, possibly the bone marrow. And now you've basically turned it on, and all it's going to do is sit there and produce antibodies. And you can see here, they produce a lot of antibodies very, very quickly. The estimate is that a activated plasma B cell can produce about 10,000 antibodies per second. Now, luckily for us, that is not forever, because again, once we kind of start this process, we're hoping our body will take care of it. And so we don't need to continually produce these antibodies because we're hopefully going to get rid of what's there and we won't need them anymore. And so usually what you'll see is the plasma B cells will start working and they're going to keep working, but they have a relatively short lifespan. And so, I haven't really touched on this at this point before, but it is something to always consider. While your immune system is great and does what it does, it kills cells. That's its job, is to kill off cells. And if your immune system is always constantly working, we may be killing stuff off, but inherently you're probably going to cause a little bit of damage to your own self, to the normal things that are there. It's kind of collateral damage, I guess would be a nice way of describing it. And so when we talk about an immune system, we want it to work and work really, really well when we need it. But when we don't need it, we want it to turn off, because having all this stuff circulating around potentially is going to cause some level of damage to our self cells, the stuff that's supposed to be there. And so the plasma B cells turn on, work for a while, and then basically turn off. And that's great. Now, but this also can explain why sometimes you have a disease, like say the flu, and then it goes away, and then you can get it back. And, it's not a 100% forever production. It's a short-term fix to a short-term problem is what we want. That's what the plasma B cells do. However, it's silly to go through this process over and over and over and over and over and over and over again. I mean, if you're exposed to something at one point in time, there's an above average chance you're going to be exposed to it again and again and again. And a great example is, for example, when you have children. My son brings home more bugs and crazy things from school than I probably even want to know about. But, he comes in and he brings them home, and usually his father and I both get sick, and then it goes away, but then he's going to bring it home again, and we'll get this kind of continuous type of exposure. And so because he's basically in the same place every day, exposed to the same people every day, who are carrying around the same bugs every day. And so while the plasma side of the B cell production is very helpful, it actually is handy if we could have some mechanism by which the body remembers. Because going through and mounting the immune response, activating the B cell, getting the B cell to move somewhere so that it can do its job, to the spleen or to the bone marrow, allowing it to start producing antibodies, that's still a time component. And so what the body has developed is something called the memory B cell system. And memory B cells are long-lived cells. So basically, you see an antigen, and we have some plasma B cells that are going to start making stuff very quickly that hopefully is going to get rid of this antigen. But in that component, you may also have some of what we call memory B cells. And the memory B cells are the ones that are going to sit there and say, I need to remember you because you may be important. And so instead of moving and immediately making antibodies, the memory B cells tend to kind of sit around and basically say, hey, if you need me, I'll be here. And so the memory B cells, we're still going to activate if we find a foreign body. The memory B cell is going to be activated. It's going to recognize that antigen and say, oh, I need to remember this. And then basically it's going to move off and it's just going to float around. It's just going to be there. And so if you see that antigen again, if that antigen presents itself to the body and one of these memory B cells can find it, it's going to bind onto it and say, oh, wait a minute, you're the one that did this to me before, and immediately start making antibodies. And so by having the B cells kind of floating all over in various places in the body, the chance of it coming into contact with one of these antigens and immediately saying, wait a minute, this is a problem, is going to be much better. And so what you'll end up seeing is if we can activate that memory B cell, it's still going to proliferate, it's going to form antibodies, it's going to do everything that it wants, but it is a much more rapid antibody response. And this is really designed to prevent repeat infections. And as I mentioned at the beginning of the talk, this is the entire premise of vaccinations. When you are getting vaccinated, we give you an antigen. Hopefully the antigen is not going to make you sick, but we're going to give you a small amount of that antigen. And your body is going to mount an immune response. You're going to get the B cells, the plasma B cells, making antibodies and doing things like that. But what we want is also to make some of these memory B cells. So that way, the plasma B cells fight off the mini infection that you've just given the patient or received if you're the person that got the vaccine. And then you've got these memory B cells that are now going to be sitting around saying, oh, let me wait, let me see if it's there. And so basically we are intentionally trying to create memory B cells whenever we vaccinate you. And the hope is that B cell will always be able to remember that antigen. Now, for some things, we have a ton of vaccines that work and work very well. And regardless of the controversy that you always hear with vaccines, the reality of the world is that they do a pretty darn good job of what they're supposed to do. We stimulate the immune system with a vaccine. We get you to make these memory B cells, and we hope then that if you're ever exposed to that particular antigen ever again, that the memory B cells that you formed are going to come back and fight it and fix it. It doesn't always work. I mean, sometimes we do not get a sufficient amount of immunity, or maybe, it's hard to go back in and go, ooh, let's see, did we actually make the B cell that we want to make? So not all vaccines work perfectly. More importantly, what usually happens is the antigen changes to some extent. This is why the flu vaccine is always a challenge, because basically the flu, there are a variety of different antigens or viruses that can actually cause the flu. We make a vaccine and hope that we get as many of those viruses as possible. And usually a flu vaccine is made up of 4, 5, 6 different strains of flu virus that we give to you and say, okay, hopefully you're going to do this. Now, you might feel a little sick. Some people do, because you technically are giving you a mild case of the flu, but you're hoping your own immune system is going to kick in and start this antibody or the memory B cell and the plasma B cell production. But then if you're exposed to a flu vaccine in the future, it's only going to really be useful if the flu virus, if you're exposed to the flu virus in the future, you have to get the virus that you've already been vaccinated for. So, if the strain of flu that you pick up this year, if you got your flu vaccine, you get the flu, it could very well be not that the vaccine was bad, but it could be that the vaccine wasn't made to fight off the particular strain of flu that you actually have. So vaccines aren't perfect, but they're pretty darn good at what they need to do. So that's a kind of a quick review. I know it's pretty skimpy, but believe me, you don't need to know a whole lot of that. When I ask for things on an exam, my exam questions tend to recognize the fact that you are not immunologists, nor will you ever need to be. So if I were you, I would make sure that you're comfortable knowing what the different types of cells are and what their role is in particular. So the plasma B cells do this, the helper T cells do this, and that should be more than sufficient for what you need to know in terms of the exam. All right, so for the last part of the talk, we're going to talk about problems, because while it's an amazing system, the immune system is not perfect, and sometimes things don't go the way that we want them to go. And so in certain situations, you can actually have the immune response respond inappropriately. And so basically not do its job, or not do the job the way that we expect it to be done. And there are several types of abnormal immune responses. We usually classify them into kind of broad categories. Hypersensitivity. First of all, we become overactive. We're overly sensitive to what's going on. So basically it's ooh, there's something weird, let's just do something about it. We don't even know necessarily if it's bad. We're just going to fix it. Autoimmunity is where your own immune system turns against your own self. So we talked about how we had the ability to differentiate between self and non-self. That system goes wrong in some patients. And so basically what happens then is your own body starts attacking your own body tissues, or your own self. And so the immune system sees an antigen, says, oh my gosh, there's something wrong with this. Well, it turns out it's a antigen that should be there, but your body doesn't recognize that. And so it starts trying to kill it off in order to get rid of it, when in fact it shouldn't be getting rid of it. The last one, which is pretty broad, is what we call immunodeficiency. So immunodeficiency means that if an antigen shows up, your immune system is unable to handle it appropriately. It could be because our signaling is wrong, where these helper B cell, or the B cells and the helper T cells and the T cells just aren't recognizing the antigen. The other thing could be that we're just not making enough. I mean, obviously HIV and AIDS, in that particular case, one of the things that goes down very quickly is T cells. And so you basically form an immunodeficiency type of situation because you don't have enough T cells to actually do the job that they're supposed to do. And so now when you get an infectious process or a foreign pathogen or something like that, you may still have some T cells, but they may not find it because they're not well dispersed throughout the system. And so unfortunately, if we don't find it and fix it, it could proliferate and grow, and then eventually it gets to a point where your immune system is not significant enough to overcome it. And so that's the kind of stuff that actually happens. Now, why do I bring this up? Well, because some of these types of things are related to adverse reactions to radiopharmaceuticals. I mean, really what we want to talk about and what you care about is, how do I know a patient's going to get an adverse reaction? And towards the end, we're going to talk about how do you know how can you figure out what to do and to determine if this is a result of an adverse reaction. But quite a few of the adverse reactions that we're going to see to radiopharmaceuticals are either allergic or hypersensitivity type of reactions, or anaphylactoid or idiosyncratic reactions that are all related to the immune system. Now, some of the other ones, mechanical, nonspecific causes, those are adverse reactions that have nothing to do with the immune system. And we'll talk about a couple of them just so you recognize what those are. But we're really going to focus on this idea of a patient having an adverse response to a radiopharmaceutical and trying to see if we can tie it back to the immune system, whether it be the appropriate function of or the inappropriate function of the immune system. Now, I know this is a busy slide and you should not worry about actually memorizing it, but one of the things that we talk about when we talk about antibodies is we don't just make one type of antibody. There are several types of antibodies that are going to actually be produced when your body recognizes a foreign antigen. You can also see that, as I have kind of on the back end here, I've got lists here that say Th1 cells or helper T cells 1, helper T cells 2. The thing that actually happens in this process, when you activate your immune system, it's not just one cell going and finding another cell. Your body secretes a whole lot of different components. We try to pull more mediators in to help. So we secrete substances that will actually pull other substances in to try to help kill off these cells. And unfortunately, in a lot of those cases, when we are going through that process, some of the stuff that's being released to pull them in are going to cause hypersensitivity type of reactions. So, as I said previously, the immune system is a great system and you want to be very happy that you have it, However, the physical act of the immune system is to kill something. And, if you're secreting stuff that's going to kill a bad cell, it inherently makes sense that some of that stuff that you secrete could cause damage to normal cells as well. And so that's why we like the idea of having an immune system that does its work very quickly and then turns itself off so that the rest of you isn't impacted by the stuff that's actually going on. If you started your immune system and it never turned off, eventually that would be bad for you, because all of the secretions and things that are going to be happening as part of the immune response are going to end up causing damage to your normal cells, which you don't want. And so, this is why we say this is a really remarkable system, because it figures out what to do, it does its job, and then it stops, so that basically we don't cause any excessive damage to the person that is being protected. So I mentioned hypersensitivity and allergic reactions. Because these are probably going to be some of the things that you're going to see. Patient may have a particular symptom, itching, but more times than not, this really is more of a hypersensitivity type of reaction than anything else. So what we consider to be immune-mediated reactions is basically where the immune system turns on, and it may very well do what it's supposed to do, but your normal immune system, just as part of its normal function, is going to have these toxic markers that are being excreted, and your body's going to respond to that no matter what. Now, the nice thing, I guess, for hypersensitivity reactions is usually hypersensitivity reactions or allergic reactions are secondary to an immune system that's already been primed to recognize this a particular substance. And so basically we call that a pre-sensitized host. So most people are not going to have a severe allergic reaction to something when you give it the first time. But as we talked about, for example, with your memory B cells, once I've gotten something, even if it's as innocuous as we think for an MDP, when you put MDP in your body, your body may recognize that as not being normal. And so even though you may start an immune response, maybe the immune response says, yeah, but this really isn't toxic, so it's not a big deal. But if I formed a memory B cell sometime in that process, it may, next time I get MDP, that memory B cell may recognize it and go, whoa, wait a minute, that's not supposed to be here, boom, and all of a sudden start an immune response. And that's what we tend to see with hypersensitivity or allergic reactions. And so we have this pre-sensitized state, you're exposed to something else or something a second time, and then all of a sudden your body starts by releasing histamines and kinins and starting the whole immune system, and basically we see adverse effects related to that. Now, I'm not saying the immune system is necessarily going to go haywire at this point. It may start this process and go, oh, wait, we've seen this before. It's not that big of a deal. This isn't going to hurt this person. We're going to kind of shut ourselves down. But you still may see the effects. And this is important for you as nuclear medicine technologists, because these are the kind of things that you should be looking for. We know patients don't always tell us the truth. So if I said to somebody, oh, have you had a bone scan before? They're going to be like, I don't know. Or they'll say no, when in fact they had one 2 years ago. And so if you've had one before, there is always the possibility that you have pre-sensitized your immune system and that there may be a complication when I give it to you a second time. Now, luckily for nuclear medicine, we don't have people who get 80 million studies one day after day after day. In traditional drug therapy, this is much more of a concern because I'm giving you a pill, but I'm giving it to you 1, 2, 3 times a day, and you're going to take it day after day after day after day. And so inherently in that process, you are being exposed to that particular material a lot. In nuclear medicine, you're not going to have a patient that has that. They'll get a dose, and they may get a second dose. They may never get a second dose, and at which time, whatever they formed in the immune system does nothing because it's not bothersome. But this is what you need to look for, because you need to be able to recognize what a hypersensitivity type of reaction is. Because what we worry about is hypersensitivity is one thing, where I have an effect secondary to the fact that my immune system is kicking in, but my immune system is going to be smart enough to say stop and turn it off and everything's going to go back to normal, versus those patients that are going to go right to anaphylaxis and or create such an immune response that basically your body shuts down. And so you need to be able to recognize what is a mild hypersensitivity type of reaction, or one that's going to be more concerning. You also should be able to recognize when you talk to a patient and be prepared. If I have a patient who's never had a study before, they can actually have an anaphylactic or anaphylactoid type reaction, but I'm much more concerned about the patient who had a study before, because I know they've already been primed, and so then there is a possibility that their immune system is going to go nutso as soon as I give them this next exposure of whatever the antigen is going to be. So I'm going to list these. I don't care that you remember IgE versus IgG versus whatever. We're just going to talk about the types of hypersensitivity in general. A type 1 hypersensitivity reaction, even though I don't care that you memorize this, basically when you have plasma cells that are going to be involved in this, they will secrete these IgE antibodies. So basically you see a antigen, a B cell recognizes it, and then basically you make all of these antibodies, and the name of this particular type is IgE. The IgE then is released, and they are going to bind to things like mast cells, basophils, things that are normally or floating around in your system. And these are what we call now sensitized. So now the next time you see that antigen, and in the example they gave here, it was ragweed pollen. So basically they were exposed to ragweed, they formed IgE, the IgEs got onto the mast cells. Now, if you come in contact with ragweed pollen again, the IgE is already sitting there. It's going to find that antigen, but it's attached to a mast cell. And a mast cell is another one of those cells that releases a whole bunch of stuff like histamine and cytokines and other mediators that are basically going to try to get the body to say, wait a minute, we need to fight off this issue. And when those cells degranulate and they release all of these factors, it's the chemical factors that usually cause the characteristic symptoms of an allergy. And so again, if you've already been primed for this, the usual presentation of adverse reactions is going to happen within 15 to 30 minutes of the time that you expose the patient to them. So, an allergy-prone person, if you get the first administration of a radiopharmaceutical, is probably going to make the antibody, but not a big deal. Now, all of a sudden, they come back to nuclear medicine 6 months or a year later. You give them a second injection. If they would have done this process, all of a sudden, you're going to see them getting itchy rashes and things like that. And so usually that's kind of where you're going to sit there and the patient's going to be on the camera going, oh man, I'm starting to itch, or, oh, I'm feeling a little short of breath, or things like that. The reactions that you get to this process, and again, this is just another little bit more detailed picture, they can be local. So, sometimes it's just, a little bit of itchy rash in the area where you injected. Sometimes it is systemic. And so you're going to see, shortness of breath and or throat problems and rashes all over the body. It really just depends. It can actually progress to a point where you have a very severe anaphylactic reaction. Now, when you look at this, there are certain populations that are at greater risk for developing an anaphylactic type of reaction. And basically, anaphylactic is the one that you worry about the most, where all of a sudden you give them something, it seems incredibly innocuous, and all of a sudden you've got a patient who's coding on your table. But if their immune system is primed for this kind of aggressive response, sometimes the immune system just starts and we can't do anything about it. And so, usually you'll see, and this from your perspective when you actually are talking to patients before you put them on the camera, usually younger people tend to have this problem, kids and things like that. Women tend to have more anaphylactic or have more hypersensitivity reactions than men. It doesn't mean men can, it just means it tends to be that way. Usually if you are talking to a patient, asking about other allergies is not a bad idea. If they get hives or they get strong responses to something pretty basic, like let's say a strawberry, we're not saying you're going to have an allergic reaction to MDP, but it does tell me that your immune system is a little hypersensitive. And so, that might be a patient that I watch a little bit more closely than a patient who comes in and says, I really don't have any allergies or anything like that. So really for your perspective, that's not a bad question to ask is, are you allergic to anything? Not just medicines, but foods and things like that. Now, there is another type of reaction that we call the anaphylactoid reaction, or also called idiosyncratic reaction. Because basically these, you get the same general idea, but this isn't actually caused from your immune system. You can still give a patient something and you can still stimulate the release of histamine and other substances, and you get that same kind of toxic symptoms and things like that. The problem though is you never actually stimulated your immune system. So if I went in and I took a blood sample, I wouldn't find any monoclonal antibodies floating around because you didn't make any, because you didn't actually turn on your immune system. You cause the release of all of these substances and you're going to get the same effects, but it's just kind of a crazy weird thing. So sometimes we're going to get a patient that will have an effect and we just look at it and go, I have no idea why you got that, because I can't explain it because of the pharmacologic properties of the drug. If I tested you, which we don't always do, you have no immune mediators, which makes me think that you really aren't kicking in your immune system, but you're still going to have the same signs and symptoms. And really for us, it's really just kind of differentiated based on the severity. If it's a mild type of thing, it could be more of an anaphylactoid type of reaction. But if a patient's had a problem, these are the patients that you want to be careful with, because I don't know. Maybe it was just an anaphylactoid reaction that caused them to have itching after you gave MDP last time. It could be that when I give you MDP this time, you have nothing. It could be that I give it to you and you have itching again, and it's not an immune-based response. Or it could be that I give it to you, all of a sudden you progress quickly to anaphylaxis because you just made your immune system go haywire. So that's the negative with this kind of stuff. And if you think about it, we always tell you, you've got a crash cart in nuclear medicine. You can call a code whenever you need to, but you can't predict in a lot of these cases. And so it's unfortunate, but it's just the way it is. Now, the kind of things that you want to look for in these, your skin, a lot of people will have rashes or itching or things like that. Actually, most people are going to complain of that when they have either an anaphylactic or an anaphylactoid reaction. You also should pay attention. If you've got a patient on the camera and they start leaning over and itching their arm, and then 2 seconds later they're doing it again, some of these people won't tell you. And, but you look for the signs and the symptoms that make you think, look at, they're itching a lot, or they're, moving around because they don't look very comfortable on the camera anymore. And, that's a great time to ask a question. Is there something going on? Or I'm feeling some itching and, I'm just not very comfortable. Okay. Doesn't mean you stop. It just means that, okay, I might keep an eye on that person a little longer than I would. I'm not going to walk away for the next 5 or 10 minutes to make sure that we didn't actually progress to something more severe. A lot of people will have respiratory-based issue, shortness of breath. They feel like their chest is heavy. Some will have gastrointestinal type of symptoms. Some will have cardiovascular, which is basically palpitations or an increase or decrease in the blood pressure. Most commonly, though, you're going to see some of the really mild, basic type of things. If you have a patient who actually progresses to this, obviously if they go into severe anaphylaxis, advanced life support, cardiac airway life support, supplemental oxygen, we can give a patient epi. That's what we do with most people who we know have severe allergic reactions. So for example, if you're allergic to bee stings, we will give you epi to try to mediate that. It opens your airway, it helps boost your blood pressure, and it basically will hopefully help mediate the effects of the immune system. If we know that you have a significant problem, some people will get steroids. It's really not better than epinephrine, but I don't want to be sticking myself every 5 seconds when I feel like I have an effect, like I would have to do with epi. So for some people where we know their immune systems are a little out of control, we give them steroids to kind of tamp it down and keep it mild. And it's very easy. We can take it orally, and we can kind of keep the immune system in check as a result of the corticosteroids. Antihistamines are used. I mean, in theory, one of the main things that happens here is we release histamine. So I give you an antihistamine, and in theory, it should block that and prevent that kind of problem. Antihistamines work much better before as opposed to after. So in theory, they should work and work well, but obviously if I'm talking about somebody who's just a little uncomfortable and I'm just trying to make them feel better, sure, I'd give you an antihistamine. If I think you're getting ready to go into anaphylactic shock, an antihistamine is probably not what you want to start searching for. Sometimes if we know patients have had responses to particular drugs before, we may tell them to take an antihistamine before they come in to try to help mediate some of those responses. But on the other hand, you also, it's hard to differentiate and decide if the patient's response before was actually as a result of an immune reaction, and so it's kind of a hit and miss on those kind of things. So the second type of hypersensitivity is what we consider to be the type 2. This one, as you can see, IgG and IgM antibodies are what we're talking about. Same general idea, but in this case, it's where the immune response is based on antigens on a patient's own cell, which means it can either be the immune system fighting off your own self, intrinsic, or your own body tissues become the self-antigen. That's a problem, and that's a immunologic problem that we have to deal with. But we also will find that some antigens will actually absorb onto a cell surface, and if that cell surface happens to be my cell surface, if that's where the antigen is, my body is going to come find it, and it's going to fix it, and it's going to kill the cell where that antigen is, even if it's my cell. So, this is the kind of stuff that sometimes we will see. And this is what we call an antibody-dependent cell-mediated toxicity, where basically the cells with the antigen are tagged, and then basically your immune system is going to come in and actually try to kill them off. It can actually lead to anaphylaxis, especially if you give multiple doses of the antigen. But the thing that's different about this, even though we call it immediate, it can actually occur up to hours after exposure. So type 1 tends to occur very quickly. Type 2 may develop over a period of time. So when you actually have patients that are in nuclear medicine, they look fine for a while, and then, as they're getting ready to leave, they're like, oh, I'm starting to get itchy. It could be that they're actually having a type 2 allergic reaction to what's going on. So again, you should always be paying attention to what your patients say as they're going through the imaging process. You may just have a very mild reaction, but if I have a patient who's walking out the door after an hour-long imaging procedure talking about how they noticed that they're getting more itchy, I'd probably have somebody take a look at them before they left, just to make sure that this isn't a major problem. Or keep them for another 15 and 20 minutes and try to evaluate if it's getting worse or better. We see this type of reaction a lot with various drugs. So and pharmacologic treatments that we use in patients. Type 3 immediate hypersensitivity is what we call an immune complex hypersensitivity, where there's an excess of antigen. Those antigens are not bound to an organ. They're basically just floating around. And so what happens is you've got this lone antigen just kind of hanging out there, and the antibody finds it and says, oh wait, I should be binding to you, and it binds to it. And what you end up with is what we call an antibody-antigen complex. And that antigen-antibody complex, if the two of them combined are big enough, what happens is they're going to kind of circulate. They're just going to follow the blood around the body. And basically what happens is usually the liver is going to scavenge those out and scavenge them out pretty well. But sometimes the ones that are a little smaller may float around for a while before they actually get removed by the body. And the problem is that if the complex together is large enough, sometimes it will actually deposit in various places. They get stuck in small blood vessels because now the antibody itself would have passed through, the antigen itself would have passed through, but the antigen antibody complex is big enough that it actually wedges in a capillary. And so now it's going to sit there. And sometimes it gets deposited in your joint spaces. Sometimes it can actually get trapped in the kidneys as blood is getting filtered through the kidneys, the glomeruli of the kidneys. And so basically it's just stuck there. So now all of a sudden you've got a complex. It's sitting in a tight space, and the complex itself is an immune-based complex. So what's going to happen? We're going to have neutrophils get activated. The white cells are going to move there. We're going to release all of these toxic complement and histamine and things like that. But right now they're stuck in one spot, so it doesn't move. And so what you'll see is the symptoms related to that. So if it's stuck in the capillaries near the skin, you may very well see a skin rash like you see in this picture here. If it's stuck in the kidneys, you may start seeing your kidney function decrease secondary to these little mini blocks. If you have them in your joints, you're going to start having people complaining of joint pain. Now, this type of hypersensitivity, because they're floating around and just kind of eventually meander to where they're going to be, sometimes it may take hours, days, or weeks for this to actually develop. And that's where some things get a little complicated. If all of a sudden I develop a rash tomorrow after I had an MDP study yesterday, is it from the MDP or is it from something else? And unfortunately for us, and one of the hardest things to try to track down when we talk about allergic reactions to radiopharmaceuticals is when we get into some of these delayed hypersensitivity reactions, it's very difficult to directly relate it back to the administration of a radiopharmaceutical. Because as soon as the patient walks out our door, they're going to be exposed to a million other things that could have also caused the hypersensitivity issue. So unfortunately, it's usually grossly underreported because your patients are the same way. Oh, I got a rash. They don't immediately think, yesterday I had an MDP study, I bet that's what it's from. They'll think, oh, I touched something, or I got some cleaning solvent on me, or, So for a lot of these kind of things, they're not necessarily dry. They're not actually tied back. The last type of hypersensitivity, what we call type 4 delayed hypersensitivity, is, again, a cell-mediated immunity. It's not an antibody. The cytotoxic T cells and the helper T cells recognize an antigen and they start the immune process. But usually this type of reaction, it takes a while for the immune system to go, wait a minute, I don't know if I like that. So it wasn't severe enough to trigger oh my goodness, we need to fix this right this second. But over a period of time, the T cells and everything kind of look at it and say, yeah, there's an antigen there. Maybe we should do something about it. And so usually it takes a little while before you actually get a reaction. So same idea, you're going to eventually stimulate the immune response. It's going to kick in. It's going to start releasing all of its mediators, but it might take 24 to 48 hours before that actually happens. Poison ivy is a great example. You can go out and rub your arm in poison ivy. You're not going to get poison ivy instantly, but within a day or two you are. And so that is a perfect example of a delayed hypersensitivity type of reaction. So those are the things you want to look for. I mean, they're very nonspecific, but the problem that we have is nonspecific could be completely nonspecific and have nothing to do with anything, or it could be a prelude to an allergic type of reaction. And so, when you have your patients that complain of these things, itching and rash and shortness of breath and all of that, take them seriously because it could be a true allergic type of reaction. Knowing if the patient was exposed to any of the drugs that you're giving them beforehand is also not a bad thing to know. So, again, if and I keep using MDP as my example, it's not that that's a stellar star of allergic reactions in our world, but, if I know the patient had MDP before, then I might be a little bit more cautious and watch that patient a little bit more closely, just to make sure that nothing unusual happens if I have to administer it a second time. So that's where you get to play a little bit more of a role, is trying to figure out what's going on. But unfortunately, it's challenging. And as you're going to see, I'm going to give you some examples here at the very end that will give you some indication that this is not as easy as you think. Other types of reactions, I had them on here, and I'm just going to briefly touch on them. Pyrogenic reactions, usually if you have some kind of contamination with gram-negative organisms, when that gram-negative organism is lysed by the body, or however it gets lysed, it's going to release bacterial byproducts, which basically are different endotoxins and stuff. And basically what will happen is, if I give that to you or to a patient, the patient is going to start getting very typical symptoms: fever, malaise. I mean, they really feel like they have the flu. And so that is not an allergic reaction, but it's a reaction to the drug that you've just given. We don't do a lot of intrathecal administration anymore, but we can actually, and it was one of the things you always looked for when we did indium DTPA administration, we are injecting a radiopharmaceutical into the cerebrospinal fluid. And, we always worry about, do not have any contamination, no bacteria, anything like that, because basically your immune system, the cerebrospinal fluid and the meninges that cover the brain, we have very little immune response in that area. And so if I inject you with bacteria, chances are good it's going to grow and grow like crazy, leading to an infection called meningitis. And so bacterial meningitis is usually the one that we kind of are like, let's watch out for. You can have viral meningitis, but the other things that can happen, which is something that we will see in nuclear medicine. You can also just have flat out chemical irritation. Just the physical act of putting DTPA into the cerebral spinal fluid for some patients is enough to create an aseptic type of situation where you have meningitis, which is the inflammation of the meninges, which covers the brain and the spinal cord. And so, if we have a patient who presents with what we think is meningitis, especially after a intrathecal puncture, we will puncture again, take out some of the spinal fluid, and try to evaluate if you have bacteria or virus or fungal or whatever in there. Sometimes there is no answer. It's just a chemical irritation. But I wouldn't be giving that dose to the patient again unless there was a really good reason for doing it. But that is not an immune response. And you have some of the same kind of things: headache, muscle pain, drowsiness, confusion, but basically that is not an immune mediated type of response. So basically I'm not going to spend a lot of time on that. You're going to see with radiopharmaceuticals that we do have some weird other reactions, and a lot of them are what we call concentration dependent. Sestimibbe, for example, one of the things patients complain about all the time is a weird taste in their mouth after injection. You just injected a bolus of a material that they're not used to having. As it hits the mouth, they're going to notice. I mean, it's copper complex, and so it's just like when you chew on aluminum foil. You get that weird taste, and no, I don't chew on aluminum foil, but you get that weird taste in your mouth. And so, but it goes away very quickly, because as the drug gets dissipated and spread out throughout the body and starts getting removed, it's just not as noticeable because the concentration goes down. But when you have patients that complain of that, of flushing, of a headache, dizziness and nausea, sometimes they are very transient, like, I'm feeling a little nauseous. 5 minutes later, they feel fine. Really, not allergic reactions. Those are very typical. If they have them and they start going away very quickly, it's probably just a transient reaction. You're going to see that a lot of patients will be so stressed out about getting injected that sometimes their vasovagal type of symptoms will kind of kick in. And so it's the vagal nerve that basically stimulates, they're stressed out, it gets stimulated, and they're going to have the anxiety, they're going to have hypotension, they're going to get bradycardic. But usually it's, oh my gosh, they're coming at me with the needle, you get stuck, you have this response, and then the patient realizes, you're not going to stick me again, and everything goes away. So usually that takes care of itself. I put this in here just because we're talking about reactions to radiopharmaceuticals. Obviously, a reaction to a radiopharmaceutical like iodine 131 would be myelosuppression, sialadenitis, which is the lack of salivary gland production. That's radiation, not the drug. It's still an adverse reaction to a radiopharmaceutical, but it's an adverse reaction to the radiation of the radiopharmaceutical, not the drug itself. Luckily for us, the reactions to radiopharmaceuticals are incredibly rare. We give you a small amount of material. Most of our drugs have no recognized pharmacologic action. And as I mentioned before, you don't give it to them over and over and over and over again. But we do sometimes see some examples. And this is also where I encourage you that if this kind of stuff happens to you, that reporting it is excellent, because a lot of people have this and just go, it was an allergic reaction, and you move on. But, being able to document this kind of stuff and to allow people to see what to look for is always going to be handy. This particular example was a patient who had a history of breast cancer, who had had an MDP study about 18 months earlier. They came in, they injected her. She didn't really, she didn't really have any problems while she was there, but she called back and she the next day and was complaining about, she had a rash and she just was feeling awful and her eyes were puffy and swollen. And, so the patient did eventually present with a delayed type of reaction where basically, she experienced symptoms a little later. So the patient had no problems in the department. She went home and everything was fine, but she called back the next day complaining of these things. However, while she was in the department, this was what was noticed. And you can see this bone scan, hopefully you recognize, does not look normal. And basically, we have an awful lot of liver and even some kidney uptake. And so that was a little weird, but, okay, an abnormal distribution. Did the radiopharmacy make it wrong? But then all of a sudden, your patient starts complaining of the allergic reaction type of symptoms. Well, normally, as I mentioned previously, when a monoclonal antibody binds to an antigen, usually those things are going to be removed from the body by the liver, because that's what the liver does. And so a reason for having this, or they're going to get stuck in the kidneys, like we talked about with the glomerulus, where basically it can't clear through. The glomerulus is too small, or the vessels of the glomeruli are too small, and they just get trapped in the kidneys. And so the question now was it just an abnormal distribution? I mean, you don't see any hot spots there that are indicative of metastases, but now after having the patient call back and complain of having this rash and things like that, now you look at this picture and you say, I wonder if maybe there was an antibody-antigen complex that was formed that got scavenged out by the liver. The reason why we see it is because it was radioactive. And that basically now this is a possible immunologic reaction. Now the question becomes, and it's a perfect example because she's already been exposed to the drug. So she had an immune response that was kind of pre-primed. She had it, she got the drug, and she saw some of this. If she has to come back for an MDP scan again, I would be more concerned about this, because maybe the next time she gets it, the immune response might be a little bit greater. And instead of having a skin rash 24 hours later, maybe she's going to have an anaphylactic type situation while lying on the camera. So, so it is possible. Now, we didn't say this absolutely was an immunologic reaction, but it really strongly indicates that given all of the things that tied in together, previous exposure, weird distribution, and then 24-hour later, patient complaining of allergic type symptoms, gives you a pretty strong impression that it could be based on that. We used to give, this is an old study, but but again, not a whole lot of data is out there. But this was an 18-year-old from the Netherlands that actually got basically labeled albumin, or MAA, and within 2 minutes, shortness of breath, coughing, the blood pressure changes. She lost consciousness on the camera. There was also a 71-year-old female that immediately following injection had a flushing and went into anaphylactic shock. And so, it's hard to look at these things and not say that it wasn't an allergic reaction. Now, again, unless you drew blood and figured out if they had antibody production, you don't know if it's anaphylactic or anaphylactoid. Anaphylactoid meaning just the release of the markers, but no immune response. But these are the kind of patients where we probably don't want to give them again. Now, luckily for most of these patients, most patients aren't in line to get a second MAA, so the chance of them getting exposed to this drug again may be slim. But if you don't mention it and somebody else doesn't mention it, and they go to a different institution to get injected with a drug, they may have a much more severe reaction, and we just don't know about it. This was a clinical study. This is actually not a radioactive drug, but again, the point being is in this particular clinical trial, they gave subclinical doses, or basically non-pharmacologic doses of a particular antibody that they were testing for treatment of leukemia. And a majority of the volunteers developed anaphylactic type of responses. And so the point of this is basically it doesn't take a lot. And so I think sometimes people say, oh, radiopharmaceuticals, we give you so little that you couldn't possibly have a reaction. You could have a reaction. And so you should always be prepared. The last thing I have on here is a drug that none of you are going to be familiar with because it's no longer on the market. Nutraspect was a monoclonal antibody that was created with the idea of replacing white cells. And the idea here was that it would actually bind to an antigen on activated white cells. And so if you had an alert or a infectious process and the white cells were migrating there, we would give you Nutraspect. It would bind to those white cells. And the white cells would carry the monoclonal antibody to the source of infection, and you could image, just like what we would do with a labeled white cell. And so, unfortunately, this particular drug was pulled from the market because as a result of the testing, they found several patients that had very severe life-threatening events: cardiac arrest, hypoxia, hypotension, cardiopulmonary failure. There actually 2 patients died as a result of the administration of this. And so the idea, because this particular product was a murine antibody, that it actually hyperstimulated the immune response in a lot of these patients and led to these kind of problems. Now, when we look at a drug, in this particular case, Nutraspect, we had something that we could use in place of it, labeled white cells, and it wasn't for a life-threatening condition. So, we're looking for an infection, and while it can be life-threatening, it's not the end of the world. We can do other things to find it. And so Nutraspect actually got pulled from the market because of the potential of these types of reactions. Now, if you look at Zevalin, for example, and the corresponding monoclonal antibody that we use in Zevalin, which is Rituxan, it turns out that we have similar warnings on that because that also is a monoclonal antibody and it can cause exactly the same problem. The difference is Rituxan and inherently Zevalin, basically that's an only option. You've got a disease state that's going to kill you. You need to treat it. And so we can deal with the immune component of it, hopefully, or we can watch more carefully for the immune component of it in the hopes of actually saving a patient's life. Nutraspect wasn't going to inherently save somebody's life, and even if it was going to, there were other options that we could use. And so this drug, after several of these life-threatening events happened, was actually pulled from the market. So we have had a radiopharmaceutical that has these kind of problems. Now, this last slide, I just give you just the good news. I mean, these are several articles relating to adverse reactions in radiopharmaceuticals. And you can see, PET studies, no reactions noted. In the Journal of Nuclear Medicine in '96, they looked at almost 800,000 administrations, and basically they had 18. I mean, that's a pretty small number. And same thing in Japan and in Europe as well. While there's also the possibility that some of these things go underreported, you shouldn't be looking at every patient that walks in your door and think, oh my gosh, I have to have the crash cart ready to go. The key for you is to be able to pick out the patients that could be susceptible before they get there, based on some of their backstory or whether or not they've had the drug before. After administration, to watch for a period of time for what you should be looking for to see if we see an immediate hypersensitivity type of reaction. To be able to judge if they do have a hypersensitivity reaction, whether it's going to progress to something more severe, if it's going to be pretty mild. I mean, really, you're the frontline person that's going to be able to see a lot of these things. And so you should be able to start learning how to recognize what things need to be reported and what things don't. So, but in conclusion, that's what the immune system does, and that's why you cover immunology as part of your curriculum, is to just get a better understanding of that. Again, I could go into this for hours upon hours upon hours, but I don't think it's necessary. Just recognize that you are going to have some patients that are going to have these problems. Some of them will be life-threatening and some of them won't. And if you can figure out what to look for and how to look for them, you can try to at least nip some of them in the bud before they actually become a problem. And as I mentioned at the very end, luckily the number of adverse reactions that we have to radiopharmaceuticals are pretty low, so this is going to be a very small subset of your population that you're going to see. So that's all for the immune response. As I mentioned, you're going to have some of this on your exam. The exam questions should be very straightforward because I can't lecture long enough to give you all the excessive details. Just be very familiar with the different cells, what they do, and kind of what their role is, and you should be fine for the exam.